Hello and welcome to the Long Haul. I'm Jeremy Rossman, and today we're going to talk about ivermectin and scientific communication. And it's my pleasure to have with me today Gideon, who is an epidemiologist and science writer. Gideon, welcome. It's a pleasure to have you here today.
Hi, yeah, it's great to be here.
So can you start with by just telling me a little bit about your background and how you got into scientific communication?
Yeah, sure. So I'm an epidemiologist from the University of Wollongong, and I work mostly in chronic diseases. I do a lot of research in diabetes prior to COVID. And I've been writing a blog and then some articles for various publications, including The Guardian, for some time, mostly around scientific communication in the media and how prior to the pandemic, it was all about how the misrepresentations of research in headlines. So often what I would do, it all kind of started when I looked at a headline about an epidemiological study, and I thought, that's not what the study said at all. And from there, I just kind of started writing this blog and eventually got into some more mainstream publications. But then when COVID came, everything kind of changed quite a bit. I used to write these long Twitter threads about published research and the weaknesses, the positives, et cetera, prior to the pandemic, and no one really read them. I got one or two people reading them, that sort of thing. And then I started doing it for COVID studies, and suddenly tens of thousands of people were looking at these threads. And my my blogs, usually they were saying, well, there's this headline, but actually it was in rodent research, or that actually the absolute risk difference is very small, so it's probably not meaningful to your life, that sort of thing. And then I started doing the same kind of thing for COVID, but a lot more people were interested. At the same time, I started doing some research into COVID. So I've done a lot of work now looking at the death rate of COVID-19 and a little bit into some other aspects, including the impacts of non-pharmaceutical interventions and lockdowns, that sort of thing. So now 18 months on, I've gone from a purely chronic disease researcher who used to comment about dodgy headlines to, I guess, COVID epidemiologist almost. It's been a weird kind of 18 months.
It's been a very strange ride. Yeah, that is for certain. But the need of commenting on these headlines, of actually sort of dissecting what's going on behind that, what's the science behind it, is needed, at least now more than ever.
Yeah, absolutely. And then I've also been doing a lot of kind of, I guess, fact checking or error checking in scientific studies during the pandemic. So what started off as just saying that headline is wrong has gone into a bit of saying that study is wrong. So like we found, my friend and I found a study where they'd just gotten their mathematical model incorrect. They'd done it wrong. Their confidence intervals were impossible. And it was corrected. It was this study in the Journal of the American Medical Association, quite a prestigious journal. They found that school closures had cost more years of life than COVID for school children. And I mean, basically that the study was wrong. And it's now been corrected to be even more wrong, but it's wrong in a different way. So now it's just not believable. Because now the study posits that school closures are either incredibly harmful if the children are American, or entirely harmless if the children are European, which is wild. Yeah, so recently I've gotten more into this error checking, specifically to do with ivermectin.
Right. So yeah, I mean, that whole school paper is probably an interesting topic for a whole nother episode there. But I'd be very interested to hear a little bit more about what you've been looking at in terms of ivermectin, but even sort of coming back to just that basic level. So what is ivermectin, and really why was there this excitement and enthusiasm for ivermectin? Why are we even talking about ivermectin to begin with?
Well, ivermectin is an antiparasitic drug. It's been used widely, mostly in developing countries, because it treats parasitic infections, various types of nematodes, worms. And it is something that I'd never come across before COVID, because as primarily chronic disease epidemiologist, parasitic infections that mostly occur in developing countries weren't something that I'd looked into. But it hit headlines originally as a treatment for COVID based on what appears, one of the bigger cases of scientific fraud during the pandemic. So Surgisphere, which is the company that had a database that they then could not produce that had impossible values for various countries. They had this they claimed to have this massive database of patients. But when people actually said, well, let's see the database, it didn't exist at all. And they were very famous because they had a study where that said that hydroxychloroquine was very harmful, and that caused hydroxychloroquine to be pulled from the recommendation, the various trials by the World Health Organization, and also caused the kind of use of hydroxychloroquine across the world to change overnight. What was slightly less well known at the time is that they also published a preprint on the Lancet's SSRN database about ivermectin, and they claimed that ivermectin in their fraudulent database, or database that doesn't exist, had huge benefits for COVID-19. And this was at a time when in developing countries, there really were no treatments at all, because the treatments that were being trialed first in more advanced economies were very expensive. They were hard to access. There was it's stuff like convalescent plasma was being trialed, and remdesivir, that sort of, and lopinavir or tonavir was common. Relatively expensive treatments that are hard to access in those countries. So it hit very fertile ground, particularly in South America. This preprint was adopted almost immediately into official government protocols in lower income places. So the Peruvian government, for example, started mass distributing ivermectin based on this fraudulent preprint. And then 3 months later, 2 months later, it was identified that Surgisphere probably never happened. The preprint was withdrawn. All of the protocols were removed because there was at that point absolutely no evidence that ivermectin was effective, except for some very basic in vitro research. So, lab bench stuff where we'd shown that ivermectin killed COVID in a dish. And that was the start. But at that point, the horse had already bolted. So by the time this fraudulent study was withdrawn, hundreds of thousands, if not millions of people had received ivermectin. It had already been established by the anti-establishment crowd as a drug of choice because it's cheap, and therefore the pharmaceutical industry would not support it, for whatever reason that is. And it was in use across the world. And so it started with fraud, but then it moved very much into the mainstream in countries where there were few options, so mostly developing economies.
Right. So, I mean, this is interesting because, we hear a lot about sort of ivermectin and talk right now, but, this is actually coming back to, when we were really talking about hydroxychloroquine and, coming back to that same, real set of controversial data that, is, made the headlines for quite a long time in not actually being able to find the data that all of this research was based on. So yeah, it's an incredible story. But so if you go look at countries that started to adopt ivermectin use based on that early study, was that policy, was there any pivot in that policy after that data was retracted, or was that sort of already enmeshed in sort of, this is a new drug to try, we can afford it, we can get it into people immediately?
Oh, no. Yeah. So the official policies almost immediately changed once the study was withdrawn, because the official policies are scientists who said, OK, well, this study is fraud. We can't recommend a study when we can't recommend a treatment when the only study has just been withdrawn because it's probably fraudulent. And so the official treatment protocols changed, but it had already been picked up by all of these people who are certain that it must work for whatever reason. And so the unofficial protocols started popping up saying, you should take ivermectin. And that brings us, I guess, to the part in the story where the really worrying stuff started happening.
As if that wasn't very worrying.
Well, so that was extremely bad. And it was very similar to hydroxychloroquine at that point, because hydroxychloroquine was also based on terrible and in some cases potentially fraudulent research. But the difference was that hydroxychloroquine was very popular in developed countries. And that meant that it was tested in these big, expensive trials run by the UK, by the US, and by the European trialists. And by August, September, we knew that hydroxychloroquine didn't work. August, September 2020. Because by then, the big trial results had come in, Recovery, the Solidarity trial, showing that hydroxychloroquine was ineffective in the treatment of COVID-19. It took a few more months for the prophylaxis studies to roll in, and they also found no benefit for hydroxychloroquine. But the difference is that ivermectin was never really used and was never popular in places where trials were being run, so it wasn't included in these protocols at first. Where there were trials, however, that started popping up in developing countries. And some of these trials reported truly unbelievably good results. So the one trial run in Egypt that I mean, now we know is probably fraudulent. This almost certain, this trial does not appear to have happened, and the investigators have had no good reasons for the data issues that we found. But this one trial reported that in their control group, 20 out of 200 people died. So the people who were treated with a placebo, and in their intervention group, 2 in 200 people died. So the people who received ivermectin, there was a 90% benefit in survival. And that is a sort of benefit that you see in the trials of antiretrovirals for HIV in the late 80s. That's, you give people who are dying of AIDS, AZT, and 90% of the people who would die survive.
Right. So I mean, this study is, of course, one of the key things to discuss here. One of the really big stories on ivermectin that's come out recently, and this is something that you and Jack Lawrence and Nick Brown have all been sort of researching and reporting on and discussing. So, can you just sort of walk me through what this study was, and what you all found? What are the issues with this study?
Yeah, so this study was a preprint posted on Research Square, which is a preprint server. The preprint, obviously, I've been saying it a lot in this already, but it's an unpublished research paper that is posted online in the final submitted version so that people can read it before a journal peer reviews it and publishes it. So it hasn't been peer reviewed, but it is usually the final work by a group of researchers before they publish. And the study claimed to be a randomized controlled trial where they had randomized people into 2 groups, the receiving ivermectin and not receiving ivermectin, and they had 3 groups of people that they'd randomized. So they had mild and severe patients who were randomized into those 2 groups, and they also had a group of outpatients who are contacts of COVID cases who they tested for prophylaxis. So they gave them ivermectin and saw if they got infected with COVID.
Okay.
What they found, as I said, was that the death rate in the ivermectin group was massively reduced compared to the death rate in the control group. So I first reviewed this study just without any thought that it might be fraudulent or any issues like that. And I said in a Twitter thread and in a blog that it was very low quality, and it was. It was what the research community would usually consider as very high risk of bias. They didn't report how they concealed allocations. They didn't report specific features of the way that they did the study that they should have reported, and some of the things they reported seemed to be done very poorly. And then one day, I got an email from a guy called Jack Lawrence, who I'd never met before or never heard of before. He said, "Can you have a look at this? Do you know about the study?" And I said, "Yes, absolutely." And he said, can you take a bit of a look at it? Because I've been looking at the data file and I think there might be some issues with it. And then he also said, and basically the entire introduction appears to be plagiarized. And I said, okay, that's weird. I'll have a look at the data file. And the very first check, like I didn't trust Jack's word for it. I didn't use his data file. I went to the data file that the researchers had posted on the preprint. I downloaded that data file myself. You have to pay $10 US to do it and go to a really dodgy website, but I did it. I downloaded it, scanned it for viruses, opened the file. And the very first checks that I did to see that if this data file was real or not failed. Even the most basic, simple things like what date did each person in this data file die on? And if you filter by death and look at the dates, most of the people died before the author said the study started. And they've got an ethics approval that's dated June 8th for the start of the study. And in this data file, they had about 30% of people who died in May.
Right.
So that's not consistent with a trial that actually happened.
Right.
Either the data file is completely fake, in which case the researchers would have to explain why they posted fake data and said it was real data, which is a problem, or the data is the data, and the data file does match the summary statistics presented in the paper to a great extent, not in 100%, but to a great extent. So they should explain why a data file that matches their published research was posted saying this is our data, but it's clearly fake. That data cannot be real.
So the data that was posted with the paper matches all the analysis and all the statistics in the paper, but it doesn't seem to agree with what they claim to have actually done.
Kind of. So actually, the data in that file is very low quality. And once you clean the data, it doesn't quite match their results. If you just do the summary statistics on very poorly cleaned data, it does match their results very well. But once you take, so for example, a lot of ones are entered in as 1.0 the letter, which means that they're excluded when you do run your analysis in SPSS, which is what they claim to have used.
Right.
But anyway, the basic point is, so the story goes, Jack also had contacted Nick Brown, who's another guy who I vaguely know, but not really, who now I know him a bit better, who did ran the same kind of analyses. And I mean, there are duplicates in the data. There are long sections where there are copy pasted patient records, very obviously copy pasted patient records. As I said, a lot of people who were apparently recruited before the 8th of June, which is when the study was meant to have started. I mean, the data file is fake. They absolutely cannot represent real people. So my position now is the most likely explanation is fraud. Potentially, there are some explanations that the researchers could have, such as, oh, damn, we created a fake data set for some reason, and then we uploaded that data set and said it was our real data for another reason. Maybe it's, it's classically with scientific fraud, what you get is these increasingly unlikely explanations, and then they disappear entirely. I mean, with Surgisphere, they said, we have a database and it's real. And then people started asking, send us the database, or at least send us some real raw data, and they couldn't. Or then they said, oh, we can't share it because of our agreements. And then they said, okay, so which hospitals have you signed these agreements with? And they said, we can't share that because of our agreements. And then the co-authors said, if you don't send us the data, we will recommend that you retract, that the journals retract these articles. And the guy who said he had the database said, well, I can't. And then he's never admitted that it was fraudulent, but there really are a few other explanations. And in this case, the lead author has said that we're biased against Egypt, and that there is real data, but this isn't his real data, and then hasn't sent anyone any real data.
Right.
At this point.
Right.
Maybe he will one day. But anyway, so the problem is that this study was large. So it had 600 people altogether, which was the largest study at that point. And it found a huge benefit. So this was very, very important in the ivermectin story. People read this study, it came out in November 2020, and they said, that is evidence that ivermectin should be used. It's a randomized control trial, it's the gold standard, and it's showing a 90% benefit. And so in January, people were writing lengthy articles in scientific journals saying, based on this and one or two other very low quality pieces of research, we must include ivermectin as a treatment protocol. And then other studies started to trickle in. Some of them did show massive benefits. Some of them didn't. Some of them showed no benefit at all, which is very surprising when you've got this 90% benefit in what is now fraudulent, but what was then considered to be high quality research. And it kind of, what kind of happened was you got two camps at that point. You had the medical establishment, which said the evidence isn't very good. Even these these very positive studies appear to be quite low quality. And this was the World Health Organization's official position. It still is. Even these positive studies appear to be very low quality. We need better evidence before we can recommend ivermectin as a treatment. We should be running bigger, better trials. And then you had groups of clinicians and other people who I don't really know what to call them, who decided that based on this this evidence, this very low quality evidence, that ivermectin should be promoted and ivermectin should be used for everything COVID related.
Right. And around this time, we were also seeing multiple reports coming in of sort of meta-analyses, looking at sort of all of the existing data that had been published so far. So when you look at this large randomized control trial, where you look at, having some of the largest patient sets, the largest number of people of any of the trials, if you remove that, so you have these meta-analyses designed to really look at all of these studies together and really try and piece out effects. Tell me a little bit about the sort of ivermectin meta-analyses and what the effect of sort of the removal of this study is from the conclusions there.
Sure. So, I mean, the way meta-analyses work, they provide you, or the way that the meta-analyses that most people conduct work is that they take a bunch of study estimates and they average them, and then they provide a weighting for each study based on how big it is, essentially. I mean, what it actually does, it takes the model that's been used in most of these meta-analyses is an inverse variance model. So it takes the variance, which is extrapolated from it's calculated from the confidence interval, and then it weights based on the inverse of the variance. Weights each study, provides it with a weight.
So how confident generally how confident you are about the data and how many people that study is based upon.
Yeah, kind of. So the idea is if you take an unweighted mean, you would be treating a study with 10 people the same as a study with 1,000 people, because say a study with 10 people finds an average of 5, study with 1,000 people finds an average of 10. You combine those, your unweighted mean is 7.5, but clearly that's not representative of the data.
Right.
So instead, the study with 1,000 people should have a confidence interval that's very small. Maybe it goes from 9.5 to 10.5. The study with 5 people has a confidence interval that's large. Maybe it goes from 1 to 15. So you derive a weight from those confidence intervals, and you use that to weight the study. So maybe instead of having 5 plus 10 divided by 2, you have 5 times 0.05 plus 10 times 0.95. So you weight the 10-person study as 5% of your meta-analysis, and the 1,000-person study as 95% of your meta-analysis. And so most of the weighting comes from the bigger study.
Makes sense.
And you don't need to know the exact specifics of that to understand that the bigger studies have a bigger impact on the model. This was the biggest study. It had a very, very large impact on the model. Usually in these meta-analyses, it was between 20 or 30% of the entire effect was derived from this one study. Mm-hmm. So you remove that, and it was also hugely positive. Remember, 90% benefit, which no other study found.
Right.
You remove this study, this randomized trial, from those meta-analyses of randomized trials, and either the effect entirely disappears or the effect is only marginally significant, very significantly attenuated. So it goes from like a 60-70% benefit for using ivermectin on death, so like preventing 70% of deaths,
right,
to preventing 40% of deaths or 30% of deaths. And it goes from being definite to being very, very uncertain.
Right. Right.
And then, then the other problem with these meta-analyses is once you remove this study, there's only one other study that showed a large benefit, a statistically significant benefit for death. And that study suffers from some issues very similar to this study.
Right.
It doesn't appear to be quite as fraudulent, but it is certainly low quality in many of the same ways. And the authors of that study, I will say, have refused to share any data with us, which is a bad sign now.
Yeah.
Yeah.
Well, so I mean, that's all very problematic and not very confident in terms of being able to say any, positive effect of ivermectin. But, you've recently reported on, a new clinical trial, the Together trial, and some preliminary results coming from that. Can you tell us a little bit about that trial and sort of what they looked at in terms of ivermectin and have seen recently?
Yeah, so the Together trial is a very large and pretty fantastic piece of research. It is an iterative randomized trial. So what they do is they randomize people to either drugs or the control group in a usual trial, but they reassess which drugs are going to be in their treatment groups once every, I think it's 3 months. So they look at they have a statistician look at the evidence so far, and they say, what is the likelihood that these drugs will be effective? And if the likelihood is high, they will keep testing them. And if the likelihood is low, they will drop them from the study. They actually, in their preliminary analyses, they were going to drop ivermectin, but because of the intense pressure from everywhere in the world, they said, okay, we have to keep including this. We have to have a sufficiently large sample to exclude ivermectin as a treatment, because otherwise we can't. So in this iterative design, they recruited 700 patients, 670-something patients into their ivermectin treatment group, and about 677 into treatment and 678 into their control. And these were moderate risk, so they're people over the age of 50 with at least one chronic comorbidity, so that's diabetes, high blood pressure, et cetera, who had a mild disease. So they had COVID-19 that could be managed in the community as an outpatient. So the Together trial is testing treatments for mild disease as outpatients. So these people had had COVID had symptoms for a relatively short period of time. They were relatively, they weren't very sick, but they did have risk factors that, if they did get very sick, put them at a high risk of severe disease and death. And what they found was that there's absolutely no benefit for ivermectin on preventing these people going to hospital. So the point estimate is 0.91, which means there was a 9% difference between the two groups, but the confidence interval goes from 0.8 to like 1.2. So your classic inference would be there's no effect. And the same was true for death. So people, I think 18 out of 678 people in the ivermectin group died versus 22 out of 678 people in the control group. And the confidence interval for that very much crosses zero. So it statistically, they found, or they said that there's no, there doesn't appear to be any evidence that ivermectin prevents hospitalization or death for mild COVID-19.
Right.
And when you add this into the meta-analytic model, it basically removes any effect of ivermectin for death for COVID-19. Because again, this is now the biggest trial. It is more than double the size of any of the previous pieces of research.
So with this and that sort of combined meta-analysis that's really showing no beneficial effect of ivermectin on hospitalization, fatalities, is there a future for ivermectin? Is there still more research that's needed? Where do you see things going with ivermectin from here, from a scientific point of view?
Well, I think it is worth noting that this is for treatment. So this is for mild, moderate, severe patients. There is still a question about prophylaxis. I mean, I'm not hopeful. I'm much less hopeful than I was a few months ago,
Right.
particularly because the prophylaxis literature, I think there will be several very large stories soon about much more fraud in the prophylaxis literature. That we have found at least 2 other pieces of research that we have confirmed could not have happened, as in the institutions that are meant to have conducted them have told us, no, this research never happened at this hospital.
Right.
So, and these are not randomized trials, but yeah. So one of those stories should be coming out this week. So I'm not hopeful about prophylaxis. Also with hydroxychloroquine, we saw this exact same story. People said, okay, well, it works for everything. And then it was disproven for severe disease. And they said, okay, it works for moderate disease, mild disease, and prophylaxis. And it was disproven for moderate disease and mild disease. And they said, okay, well, it works for prophylaxis. And then there was no evidence for prophylaxis. And finally, we stopped using it. For ivermectin, the story seems to be going a similar way. People said that it worked for everything. It definitely, or the evidence is quite strong now that there is at best a mild benefit, only a very modest benefit for people who have severe disease and who have moderate and mild disease. Maybe prophylaxis, there will be some benefit. It's worth noting that a modest benefit on severe disease would still be enormously beneficial, because this is a cheap drug with relatively low side effects. So if you can give this to everybody and it reduces risk of death by 5–10%, that's meaningful.
Right.
And that's still plausible. We could still find that. That being said, it is looking less and less likely that that sort of effect will be found.
Right. Based
on the evidence to date. So I think what's next is there are still 3 or 4 big trials, in particular, the principal trial in the UK, which is going to be sufficiently large to really put to rest this question of whether ivermectin works or doesn't. Once those, so at the moment we're kind of in this, I guess, twilight zone almost, where there may or may not be a benefit. The evidence seems to be indicating that there isn't, but there's a plausible benefit. And even if it's small, we need to know that, because that could be very important. In a few months' time, I think we will have a definite answer to that question.
Right. Of course, because I mean, we are constantly looking for anything that can be used to, reduce disease, prevent transmission, anything. And especially if we can find something that is a repurposed drug, something that already exists, that we have a good safety information on, that can be very affordable. This is not some conspiracy theory to, try and hide the best drugs and make drug manufacturers only be selling the most expensive designer drugs, but it's about the science. It's about the data. What do we know? And, do we actually have any scientific reason to say, yes, this is beneficial or not?
Yes, absolutely. And I mean, a great sign of that is that the Together trial found no benefit for ivermectin. They did find a benefit for fluvoxamine, which is another repurposed, cheap, off-patent drug that is now being potentially going to be included in quite a few treatment protocols, because they found that it reduces the risk of hospitalization for people with COVID, with mild outpatient COVID.
Right. Which is, of course, great news, because we're always looking for drugs with potential. But of course, this is another, point in time where we have a drug with potential, and that's great. But it's also, this comes to that sort of final point to bring up, is this aspect of scientific communication. So we have this new drug, or repurposed drug, and we have a little bit of data that says, look, there might be actually a really positive benefit here. But there's a big gap in saying, okay, we have a little bit of data here scientifically that says, yeah, there might be a good effect. We need to go study this more, because if this holds up, this could be really effective, versus saying, here's some data from a study, and now people are going out and using it. So, and this is the same thing that we saw with ivermectin. We saw, whether that was governments or just people really trying to sort of use ivermectin, because people, of course, are desperate for anything that might be beneficial. So with that gap, between, okay, this is what the data is, so this is what we're seeing in the scientific literature, versus this is sort of the public communication, this is the sort of that understanding, that clamoring for something to grab hold of, something of hope. How do you bridge that gap? How do you get that scientific communication of what we know and why it's so important to wait for that clinical trial data?
Yeah, I agree. That's a very difficult question. And I think the biggest issue in many ways is the divide between richer and poorer places in the world. Because in richer places in the world, it's very easy. You have lots of treatment options. At this point, there are, several ways that you can treat COVID, and all of them have potential benefits. And some of them are demonstrably beneficial. You give remdesivir, maybe it doesn't reduce the risk of death, but particularly if you give it early, it's going to reduce the risk of severe outcomes from COVID, that sort of thing. I mean, the remdesivir literature is also terrible for completely different reasons, but much less fraud, but much less unscrupulous pushing of a drug by a pharmaceutical corporation with massively insufficient evidence. Anyway, the point is, if I got sick in Australia, with COVID, my doctors would have many options. If I was living in rural India and I got sick with COVID, there would be basically no options.
Right.
But what is accessible is ivermectin. Even fluvoxamine might not be accessible in the middle of nowhere if I was in very rural places in India. Right. And I think that's really where the communication is important, but also very hard. Because the World Health Organization can say ivermectin shouldn't be used outside of a clinical trial, but if you've got people dying of COVID, you're going to say, well, ivermectin's probably not going to hurt them. And then the problem is if you say, well, these 10 drugs probably aren't going to hurt them, and you give all of them, one of them might hurt them.
Right.
But I do think the ivermectin story, if we hadn't already learned it from the hydroxychloroquine story, has taught us that going too hard too early on a drug that may not work is a terrible idea, and you should be very cautious in your public statements about medications that may turn out to be entirely worthless. And I think some people didn't learn that lesson, and it has been to the detriment of hundreds of millions of people across the world who've been given ivermectin for COVID.
Right. That's it.
I don't know if there's a good answer, unfortunately.
No, but I mean, at the very least, just to say that hopefully maybe now we will actually learn that lesson. I hope so.
Yeah, me too. I mean, I think the people who believe in their heart of hearts that ivermectin works are now moving away from randomized evidence because it doesn't show benefit, and they're going back to the sort of observational and ecological studies, and they're saying, but look, Zambia improved so much when this one guy recommended ivermectin, or Peru, some people took ivermectin, and look at the curve of mortality in Peru. Right. And it's interesting because it's kind of the opposite of the scientific method and of the evidence pyramid. I suspect what's going to happen is people will go back to these studies that don't show much of a benefit because they're really confounded and they're really poor quality, and they will have to use those because the good quality studies don't show a benefit.
So what do you say? If you're talking to somebody who's talking about those studies, talking very adamant about the benefits of ivermectin, what would you say to them? What's your message?
Well, what I always say is this is why this is why I think what I do, and this is why I'm not convinced by the evidence. Right. Because ultimately it's very hard to change people's minds when they're absolutely certain. And some of these people have been rather nasty about me on the media and social media, and apparently I'm paid by Big Pharma or whatever. But the reason why I'm not convinced by that evidence is because it's really bad evidence. And if you talked about that in an epidemiological conference, you would be, shouted down because someone would say, but this is trash. I've been at conferences where that happened, and yet it's being used to promote drugs to people. It's a bit of a mismatch there.
Yeah, absolutely. I mean, this is the point is, we're following the data, we're following the science, and also analyzing the science. It's not, this is not just a, blind acceptance of truth. This is a lot of scientists over the world looking at the data, doing the analysis, and coming to, observations of what's happening.
Yeah, I mean, and the other thing I would say is that, the randomized evidence may now not show a benefit, but people have been relying on this very low quality evidence for some time. And that was always bizarre, because some of these studies that are definitely fraudulent are also so low quality that no one should ever have read them and said, I'm going to treat patients based on this.
Right.
They're published in predatory journals. They have basic mathematical mistakes. The graphs are, amateurish, that sort of thing. And also maybe they didn't happen, but you shouldn't need to know that they're fraud to say this doesn't look right.
Right. So, I mean, what is your take on why that is happening?
I think people really, really wanted ivermectin to work,
Right.
and they were happy to accept any evidence that it did, regardless of how terrible that evidence was. And I think that I can sympathize with that, because I also really wanted ivermectin to work, because if there was a drug that prevented 90% of COVID deaths, the pandemic would essentially be over.
Right.
It would be absolutely amazing, and I wish that it were true, but also that appears to be largely based on fraud. So it probably isn't true.
Right. Well, I just hope we can actually learn from this lesson. But Gideon, thank you very much for coming on, for sharing your expertise, your analysis of the situation. It's been very nice talking to you.
It's been my absolute pleasure. Thanks for having me.
Thank you.